Hello everybody, welcome to Beyond the Boards, and today we're going to be talking about atrial septal defects. So an atrial septal defect is considered to be one of the acyanotic congenital heart defects. Acyanotic means that the baby does not develop cyanosis at birth, but may or may not do so later on in life. Contrast this to cyanotic congenital heart defects, in which the baby does develop cyanosis at birth. An atrial septal defect, as the name implies, is a hole or a defect within the atrial septum, which is the septum that divides the right atrium and the left atrium from one another. In order for us to understand ASDs, we need to look at the embryology behind the formation of the atrial septum first. But when it comes to the embryology behind the atrial septum formation, this might get very confusing very quickly, so I'll try to walk you through it slowly. So while you're an embryo, your heart only has one atrium called the common atrium. This common atrium will then get divided into the right atrium and left atrium by the atrial septum. Let me first introduce you to an embryologic structure called the endocardial cushions. These are essentially the structure that divides the atria from the ventricles and are sitting between them. I mention this just so that you don't get confused when I bring them up, and they also play a role in the development of the atrial septum. So the first thing that happens during the development of the atrial septum is the formation of the septum primum. Primum means primary, so it's the primary septum or the first septum, because we have a second septum that develops later on. This septum primum is going to extend from the roof of the common atrium, as you can see in this image, and it's going to extend downwards towards the endocardial cushions. However, the middle part of the septum primum is not going to extend all the way down towards the endocardial cushions, leaving a hole or an opening between the lower part of the septum and the upper part of the endocardial cushions. This hole is referred to as the ostium primum, literally the first hole. Again, this is because there's a second hole that's going to form later on. So I hope so far everything is clear. The reason why we need a hole in the atrial septum when we're an embryo is because the way the fetal circulation works. Now, I'll explain that in a different video, but essentially you don't want the right atrium to pump blood into the right ventricle then to the lungs, because you're not really using them in the womb, so no point in sending blood there. Plus, the blood that is returning to the right side of the heart in the fetal life is already oxygenated. So the hole in the atrial septum allows the blood to be shunted from the right atrium into the left atrium, which then pumps that oxygenated blood out to the rest of the body. Now, you might be wondering, why is blood being shunted from the right atrium towards the left atrium and not in the opposite way? Well, as I've said, since the lungs are not being used and are filled with fluid, this creates a lot of resistance to flow, and hence the right side of the heart has to pump against all of that, and this markedly raises the pressure within the right side of the heart, making it higher than that of the left side. And since blood flows from areas of high pressure into areas of low pressure, this blood will be shunted from the right atrium towards the left atrium. Anyway, if that's all confusing, I have a separate video talking about the fetal circulation, so please watch it. So after the development of the septum primum and the ostium primum, another hole will form at the top of the septum primum, and this one will be named the ostium secundum, literally the second hole. So what happens is that cells within the upper part of the septum primum undergo apoptosis and die, and so you get resorption of some part of that septum, and at the same time the endocardial cushions will start growing towards the ostium primum from the bottom, and eventually sealing it off. This happens at the same time that the ostium secundum is forming, so they always have a communication between the two atria. Following all of this, a second septum will form next to the septum primum to the right side, and this one will be called the septum secundum, literally the second septum, which is sensibly named. The septum secundum will grow so that it covers the ostium secundum, but leaves a little space at the bottom. Then the upper part of the septum primum, the part that is above the ostium secundum, will get resorbed, leaving the lower part of the septum primum. This opening that is created by the two septums and the ostium secundum will be called the oval foramen or the foramen ovale, and this allows for the movement of the septum primum, sort of like a one-way valve, allowing blood to flow from the right atrium into the left atrium, as you can see in this demonstration. Okay, so far so good. So this right to left shunting continues until we are born, and after we take our first breath, the lungs will be cleared from all that fluid, reducing the pulmonary resistance and lowering the pressure within the right side of the heart. This makes it lower than that of the left side of the heart, so that blood will then try to go from the left atrium to the right atrium, but because that septum primum is acting as a one-way valve, this won't allow the blood to move in that direction, and that high pressure within the left atrium will push the septum primum towards the septum secundum, eventually causing them to fuse with one another, sealing off the foraminal valley. So now let's talk about the types of atrial septal defects and how they form. The most common type of atrial septal defects is the ostium secundum type. This usually occurs as an isolated anomaly and is due to either excessive resorption or defective formation during development, and I'll show you what I mean by that. So when the ostium secundum is being formed by the death of cells in the upper part of the septum primum, in an ostium secundum ASD, the cell death will be too excessive and there will be a resorption of a bigger part of the septum primum, leading to a huge ostium secundum that cannot be closed off by the septum primum and septum secundum when they come together. This ASD type can also be caused by underdevelopment of the septum secundum to the point where it cannot close the ostium secundum normally by coming into contact with the septum primum. And that is how an ostium secundum ASD can be due either excessive resorption and cell death of the septum primum or defective formation of the septum secundum. The second type of ASD is called the ostium primum type. This one is less common and is usually accompanied by other congenital abnormalities, partly because it is due to a problem with the endocardial cushions. And since the endocardial cushions give rise to other structures in the heart, it's not difficult to imagine how this would result in multiple anomalies. So you can see that the endocardial cushions fuse with the septum primum, closing the ostium primum normally. But in ostium primum type ASD, the endocardial cushions fail to do so, resulting in a hole being left open. And there are other types of ASDs, but these are the two most common ones and the most important ones. There's another thing that I want to mention here. There's something called a patent foraminal valley. This is not really considered a true form of ASD, and because it is due to failure of the septum primum and the septum secundum to fuse with one another. This is very common actually, and it's actually estimated to be present in 1/4 of the population, so 25% of them. But it usually doesn't cause any problems because it is small and allows only a minimal amount of shunting. I think the most important complication that you need to be familiar with in a patent foraminal valley is a paradoxical embolus, and we'll talk about that in a bit. So atrial septal defects are a type of shunt lesions which cause oxygenated blood to flow from the left atrium, which is oxygenated, into the right atrium, which is deoxygenated. The direction of the shunt is left to right, as is the case for all acyanotic shunt lesions, because the pressure in the left side of the heart is higher than that of the right side of the heart. Now, if the ASD is large, then this can cause shunting of large amounts of blood from the left atrium to the right atrium, and that goes into the pulmonary circulation, and that excessive amount of blood then returns to the left atrium and left ventricle, causing volume overload, which can lead to heart failure. And this can also lead to excessive amounts of blood flowing into the lungs because the right ventricle is going to be receiving more blood from the superior vena cava and inferior vena cava, along with the blood being received from the left side of the heart coming through the ASD. In larger ASDs, this can cause an excessive amount of blood to flow through the lungs, which, if prolonged, can lead to thickening and constriction in the pulmonary blood vessels, which may be irreversible. This raises the pulmonary vascular resistance, which raises the pressure within the right side of the heart, so much so to the point where it becomes higher than the pressure in the left side of the heart. So this leads to reversal of the shunt from the right atrium towards the left atrium, and blood will start flowing in the opposite direction, and this is called Eisenmenger syndrome. The idea of a left to right shunt is interesting because it mixes oxygenated blood with deoxygenated blood, and they usually want to test you on this fact, usually using a diagram. So while normally you have the oxygenated blood coming to the right atrium through the superior and inferior vena cava, and then to the right ventricle, but then that blood goes to the pulmonary circulation, gets oxygenated by the lungs, so that the left atrium receives oxygenated blood, which then pumps it into the left ventricle and then the rest of the body. In an ASD, you have an atrial level shunt, so that in a diagram like this, you can actually see that the oxygen content within the right atrium going up before it even reaches the lungs, and this is because oxygenated blood from the left atrium is being pushed into the right atrium, raising its oxygen content. So make sure you understand the diagrams like this, and they are really simple if you just understand the shunt physiology. During the auscultation of a person with an ASD, the most important auscultatory finding is a wide fixed splitting of the second heart sound. Now, normally during inspiration, the pulmonic valve closes a little later than the aortic valve due to increase in venous return, leading to splitting of S2 during inspiration. But during expiration, both valves close at the same time so that S2 is single. In an ASD, the increase in blood returning to the right ventricle causes delay in the closure of the pulmonic valve because the right ventricle will take longer for it to pump all that extra amount of blood, so the second heart sound will always be split regardless of inspiration or not, hence it is fixed. Now, an ASD doesn't really cause a murmur per se because the pressures are relatively low within the atria, and hence the shunted blood wouldn't really cause much sound. However, the increase in blood returning to the right ventricle causes an excessive amount of blood flowing through the pulmonic valve, causing a flow murmur. This is an ejection or a mid-systolic murmur that is best heard at the pulmonic area in the second intercostal space of the left sternal border. Another murmur you might hear is a mid-diastolic murmur. This is due to flow of excessive blood through the tricuspid valve and is best heard at the lower left sternal border. However, the most important auscultatory finding in ASD is the wide fixed splitting of S2, especially in the setting of exams. The clinical features of an ASD depend on size and the amount of blood being shunted, so a small ASD can be virtually asymptomatic, while larger ones can cause heart failure, whether that be in infancy or later on if a person in his 20s or 30s. And in long-standing cases, large ASDs, the patient might also develop Eisenmenger syndrome. An important complication that can occur in patients with an ASD and a patent foraminal valley is called a paradoxical embolus. So that means when they develop deep vein thrombosis and that clot gets lodged off and travels toward the right atrium, instead of normally going to the pulmonary circulation causing a pulmonary embolus, it passes through the hole in the atrial septum and goes into the left side of the heart. Then the left ventricle will receive it and then it can pump it into the carotids to the brain, causing a stroke, for example, or through other major arteries causing ischemia to organs. So when it comes to the management of an ASD, small ones are usually asymptomatic and don't really require treatment and may even close spontaneously, while larger ones tend to persist and if are asymptomatic may require closure. Thanks everybody for watching this video. I really hope you've learned something. Please like this video, comment something nice, and share it with your friends. This helps the video get suggested to others. I put so much effort into the making of this video, so I really appreciate it when you do that. See you in the next one.